So I'm just going to introduce myself quickly as people continue to sit down. My name is Ashley McCormick, and I am the MIAM Endorsement Coordinator. I've been doing that now for 3 years. Prior to that, I was doing infant mental health home visiting in the model that Nicole described in a community mental health agency in the Detroit area. So I did that for about 7 years. So I am going to, do you want to go to the next one? Go through in some detail, hopefully not painstaking detail, all the different requirements for each one of the different endorsements. I did want to just show this off for all of you. It's in the beautiful competency guidelines booklet that I know Paige worked really hard on. So if you have any questions and from what I'm talking about and you go consult this and you still have questions, let us know. There's a lot of information in here. So this came out of the competency guidelines like Nicole talked about. And also, I'm going to have a hard time switching my language and not referring to them as levels. And you'll see even some of our slides still say levels. So just humor us as we embrace the new language. But I'm going to start by talking about infant family associate, which, like Nicole said, is those folks who are working in promotion, early care and education, early intervention, early Head Start, those kinds of settings. So we did just receive a question, so I really want to highlight this first one. This category of endorsement is unique to all the other categories in that it is an education or work requirement, so you do not need to meet both of those. So you could meet this requirement by having your CDA or associate's degree or having 2 years of work experience in the infant and family field. So this is the only category of endorsement where it's either or. All of the other categories, you need to meet the requirements for work and education. So let's see, in-service training hours is the same requirement no matter what endorsement you're talking about. You need to have a minimum of 30 hours, but it feels helpful to say that 30 hours is just the minimum. Many people find that they need many more hours than that, like 45 to 60 hours, to really meet the full competency areas. So we really want to focus on making sure you all understand that, because if you're going to be the one giving this message to applicants, applicants really need to understand that, because we do have a lot of questions. People are surprised if they don't get endorsed because they met 30 hours of training, but they really, fell short on missing a lot of the different competency areas. So just keep that in mind. For every endorsement, you need 3 references. The references vary depending on what endorsement you're going for, which I can talk about in a minute. And then reflective supervision, like Nicole already talked about, is a staple. It's not required for infant family associate, but we do encourage everyone to get reflective supervision, but that wouldn't hold them back from earning endorsement. And then code of ethics and agreement is signed by everyone. And then for infant family associate and infant family specialist, there's no written exam, whereas the other 2 do have a written exam. And then membership in ORIME, huh? Yeah. Yes, is required. So I just want to make sure I said everything I wanted to say about infant family associate. Okay, so infant family specialist is another broader category. Like Nicole said, a lot of McV home visiting program service providers would fall here. The education is bachelor's or master's prepared, a 2-year minimum work experience in the field of infant and family. And the requirements are you have to have worked with a minimum of 10 families where the identified child in the family is between the ages of 0 and 36 months. And it needs to be relationship focused and really promoting social emotional development. Let's see. And then Nicole already mentioned the 24 minimum required hours of reflective supervision. And then infant mental health specialist, those engaged in the infant mental health practice, like Nicole mentioned, need to have master's or postgraduate education experience, 2 years post-master's work experience, and it needs to be specific to the infant mental health practice. So really providing those very specific interventions like infant-parent psychotherapy, interaction guidance, something really focused on the ghosts in the nursery, the angels in the nursery, like Nicole mentioned. And then the 50 hours of reflective supervision, and then infant mental health mentor. Each one of the different designations has slightly different requirements, but the main difference about this one is that we add a leadership component. So in addition to showing that you meet all the different requirements, you also need to demonstrate that you are a mentor, a leadership in the field of infant mental health in your state. Oh, I guess one other thing I want to say about infant mental health mentor clinical is that you need to really show and demonstrate through your endorsement application that you have dedicated some of your training time and some of your own reflective supervision time about the supervision that you're providing to others. So you can still be doing the direct service work and receiving reflective supervision about that, but you also want to be receiving reflective supervision about the reflective supervision that you're providing to others, if that makes sense. So in that, I don't know what wording they have in their competency guidelines, but that is we're making that more explicit in Michigan come January 1st, 2017. So I'm not sure what wording you guys have in your. Okay, so it is much more explicitly stated. Before we just thought everyone would just be doing that. So the training requirement now says, you need some specific training hours on the provision of reflective supervision to others, and you need to be getting your own reflective supervision about it as well. Okay, I think. All right, so the competency guidelines, this is another big question that we get often, like, I'm sure if you've scanned through the document, there's a lot of competencies. So when people are getting ready for applying for endorsement, they can be pretty overwhelmed thinking that they need to meet each individual competency. And so there's 8 domains: the theoretical foundations, law, regulation, and agency policy, systems expertise, direct service skills, working with others, communicating, thinking, and reflection. So what I tell applicants in the beginning is really focus on theoretical foundations, direct service skills, and reflection. Like those are really the 3 areas that we're going to be looking for as far as training goes. Like either in-service training or courses that they took at a university or college. Whereas those other ones are usually demonstrated through their work experience or the reference rating forms, the questions that we ask the references. So really the theoretical foundations and the direct service skills are where we focus most heavily when we're reviewing the endorsement applications. So I'm going to talk about those 3 a little bit more. So you'll see the top competency areas are in bold. Those are for infant family specialist, and then the next 2 are for infant mental health specialist. The competencies build on each other. So we also have the question often, like if somebody earns endorsement as an infant mental health specialist and then they want to move on to infant mental health specialist, then you can really tell them to focus their attention on those additional competencies because it does build. So pregnancy and early parenthood, infant, very young child, development and behavior, infant family-centered practice, relationship-based therapeutic practice, family relationships and dynamics, attachment, separation, trauma, grief, and loss, disorders of infancy and early childhood, cultural competence, and then the 2 additional ones are psychotherapeutic and behavioral theories of change, and mental and behavioral disorders in adults. And then moving on to direct service skills. This one is also one that your work description could pick up some of these, but we are also really looking to make sure that they have in-service training on these or, like I said, college courses. So observation and listening, screening and assessment, responding with empathy, advocacy, life skills, safety, and then the add-ons for infant mental health specialists are intervention, treatment, and planning, developmental guidance, supportive counseling, and parent-infant, very young child relationship-based therapies and practices. So that last one really is meant to encompass the infant-parent psychotherapy, interaction guidance, the more long-term circle of security model. So you'll see those last ones are all very intervention focused that we wouldn't be expecting just like a McV home visitor to be using those interventions with a family. And then lastly, these ones are less likely to be brought up in a training record unless it was someone who was going for infant mental health clinical, infant mental health mentor clinical, but we still ask folks to really pay attention to this because we don't want to minimize the importance of the reflective supervision and consultation piece. And in their endorsement application, just like we ask the applicants to describe their work experience so that we can, hopefully get a sense of what they're actually doing in this job, we also ask them to write a description of their reflective supervision experience. And I think that that really lends us and the reviewers to understand how they view the process. And it might not be, like Nicole's, there's lots of different ways to talk about reflective supervision, but it might not be the way that we're thinking about it. So I think we just want to really highlight this so that the applicant doesn't just think that this is another fill in the blank, met with my supervisor once a week answer. So we really want to highlight that this is just as important as those other areas. So Nicole has referenced the Alliance, which you are all now part of. So all of the states in green are members of the Alliance, states and region in Australia. And then those in blue are interested, have indicated that they're interested, are in some part of the process of figuring out whether they can join the Alliance. So you'll see the Ireland's there, another region in Australia. And I do want to say that, so you are all members of the Alliance. The Alliance is still, like Redmond just said, was just official, I think last week. Yeah, a week ago. So it is very new, but the hope is that it will eventually have its own website and be its own separate thing that you can then feel part of that as well. But for now, by being part of the Alliance, you can purchase all the My Aim products on our website as through the Alliance at the membership cost. So I just wanted to share that with you. Some people are excited about that. So it's hard to get that message out, I guess. So I wanted to take advantage of everyone being in the same room together. So all of these states, I did want to say something about Florida. Florida is blue. They are interested in purchasing the endorsement, but right now they have 2 counties that are just using the competency guidelines. So they just purchased the license to use those, and they're using it as workforce development, developing training around infant mental health, but they do not have the endorsement currently. So all of the green states have endorsement and the competency guidelines, and there is reciprocity across all of the states. So I think that's another reason why the standards for endorsement are so important. We all need to be viewing it the same way. We all need to be looking at the endorsement applications in the same way and talking about them in the same way so that an infant mental health specialist in Oregon could move to Texas and they would know, oh, you did that kind of work, that's what that means to us too. So I think that when, sometimes people have a hard time with all of the different hoops that there are to jump through, I think if you remind people of that there's 24 other associations using this and that it's really important that we keep the quality control and standards the same across the states, that's a helpful reminder that it's much bigger than just you. Okay, so when Paige approves endorsement applicants in the beginning of the process. We send them what we call a getting started guide. And Nicole was just talking about it with you about using it for a crosswalk between systems. But it's essentially the competencies, all of the competencies listed individually, and it encourages the applicant to start there in their process and really sit down and say, do I have training in pregnancy? Do I have work experience in pregnancy? So that after going through that self-assessment, they can see where their own gaps are. It gives them a roadmap for moving forward. So individually, I think that's really helpful. And then some programs have used that as well, and that's what those folks in those 2 counties in Florida have done. They've used that as like a workforce development map. So they're all using that for professional development. So I do think there's real value in having crosswalks between programs as well. So you can also consider using it that way. Okay. There hasn't been research done on how effective endorsement is. There's lots of talk yet. There's lots of talk about doing that, especially like we want to know how it's helpful to the practitioner, but we also want to know how it's helpful to the infants and toddlers and their families. So there's a lot of talk about that. That's one of the exciting things about the Alliance. There's more manpower to get some of those bigger projects going, lots of different resources spread out across all the different states. So there's a lot of people who want to see this happen sooner than later. We have just done some of our own information gathering in Michigan, and then the folks in Colorado did the same thing. So we have some data. So here's just a few quotes when we asked how endorsement has changed the view and perception of infant mental health, their own view and perception. They have said, I have a better understanding of the importance of this work. I am well prepared for work with families. I obtained more relevant training and supervision than I would have otherwise. The time spent preparing my application helped increase my understanding of infant mental health work. The material for the exam deepened my understanding and increased my credibility. And then we did ask them about the benefits that they believed endorsement had to the families that they worked with. And they said, I think it maximizes my capacity to be fully present with them. I'm a more well-rounded clinician due to requirements for reflective supervision and continuing education. My knowledge and studies make me a better therapist. I'm a better advocate in court, and increased breadth of knowledge in treatment approaches. So those are just some of the individual benefits. Now we're going to talk a little bit about the system-wide benefits. Nicole already talked about the big one in Michigan, how we've had this infant mental health home visiting model in place for 38 years. That's a pretty big system-wide change that happened. New Mexico is the other state that has a similar, I think it's on a different slide, but they have something similar in place in New Mexico. So I think another change that we've seen is that the cross systems, there's more desire for the workforce development, so training, the reflective supervision and consultation. More people are using the competency guidelines as a professional development tool, which is leading more people to then automatically get reflective supervision and consultation as well. University programs, which I'll talk about in a minute, have been designed to align with the competency guidelines. Programs like Healthy Families America, Parents as Teachers, the pyramid model. There's some other big programs that there's been crosswalks done or are in the process. There's constantly more and more crosswalks that people are wanting. And then endorsement is linked to professional development requirements in some areas. Some baby court systems will only have baby court therapists be folks who are endorsed as an infant mental health specialist. And then I already talked a little bit about providing the map for workforce development. And then an example of a competency-based training that goes along with endorsement, the ounce of prevention reached out to the Alliance recently, probably less than a year ago, to say, hey, every time we bring one of these, our trainings to a state, people ask, they're starting to ask, well, do these trainings count for endorsement? Because there's so many more states that are having it. And so they were like, well, we want to make sure that it does. So we had some of the infant mental health mentor clinical folks, both in Michigan and the Alliance states, like mentor, been doing this work for a very long time. Those folks watch these. There was a pair placed together, watch them, and then have a conversation about the competencies that they thought were met in these trainings. So now if you go to the Ounce of Prevention and you were to go to one of these trainings, that would be right there in the workshop description as you register for the training. So I think that's exciting, and I think it's just showing some of the things that the Alliance, now that it's a bigger national, international presence, people are starting to take interest in wanting to go out of their way to make sure that what they're offering matches what we're wanting from folks in this field. Some other specific trainings, just so I think it's nice for people in this newer stage like you guys are now to hear a little bit about what other people have provided. So in Michigan, there was training to develop providers of reflective supervision. You'll soon know that this is a big, I think we'll talk about it this afternoon, this is part of the conversation that's constantly happening, is how do we build capacity? We just need to continue building capacity. As you know, those best reflective supervision consultants retire, we need new people who are going to be stepping up. So it's just, all of the states are always talking about this need to build capacity. So in Michigan, we received a grant to really focus on this, investing time and money in building the reflective supervision base of people that we have, I guess. So there were monthly sessions held for 3 hours, and there was just a lot of pre and post test self-exploration. That's, I think, where the self-efficacy scale came from that was developed in Michigan. So just a really, I think, Nicole, you reminded people of often, like, we need people who can provide this, but we need really quality training first to give to the people who then need to provide this. So I think that was an attempt to do this. Another model that was also focused on providers of supervision was in Wisconsin, and they focused on McV programs. So theirs was very in-depth, very complex, and it really sent home the model of parallel process. They had consultants meeting with the teams, they had a consultant meeting with the consultant, and then they had a consultant meeting with that consultant. So it really was very complex, but they had really great data that came out of that. And it was pretty long-term, 3 years, yeah. So I don't know what else I wanted to say about that.
It's in a very rural part of Wisconsin.
Yes. Yeah, and I think it's worth saying that through the Alliance, there are those connections that can happen. Like if someone here, I don't know, the lady who spoke second this morning, I'm not sure if she was is still here. Oh yes, like we could put you in touch with one of those people in Wisconsin who did this. I'm not sure if you heard what Nicole just said, but this was in a very rural part of Wisconsin. So there are those kinds of connections and collaborations that can easily happen when we're all much more aware of what each other is up to. Okay, so the next one is competency-based training for early education and child welfare. Texas really has focused a lot of their endorsement energy and time and money on early care and education. I think you'll find that each state is very unique where their needs are and where they decide to focus their energy. But they received a training grant to develop and provide training that focused on the infant family associate competency areas. And they have really made it their goal and mission to deliver these trainings to the child welfare and early care and education providers in their state. Another training that focuses on infant family associate The Rhode Island Association collaborated with Susan Dickstein, who works at the Bradley Hospital, and it is online. It is available to anyone. It's $50, and it's 16 hours, and it focuses on all of the infant family associate competency areas. And then this we already talked about, but this is where New Mexico also made some changes for reimbursement of infant mental health services. And then lastly, many different higher education programs have crosswalked their programs to the competencies. So I'll just use Wayne State as an example. That's the most popular one that someone would go to in Michigan. When they leave the dual title program in infant mental health with either social work, nursing, or early childhood education, we confidently know that they have met all of the competency areas for infant family specialist. So it's nice to do some of that work, like the crosswalking work, so that you know that one, and you guys have done that too for your program. So you know when you get one of those applicants, that's helpful to you as the endorsement coordinator and your reviewers to feel confident in those applicants. I think the last slide is back to Nicole.
So this quote up here, endorsement is a journey, not a race, is one that I actually have printed out above my desk to sort of remind me. And actually some of the other coordinators from the other Alliance member states liked it so much they literally made it into a t-shirt. So it's just helpful to remember. I know you've all worked so hard to get here, but do keep in mind, we have to remind individual applicants. You have some applicants who've been in the field forever and are really seasoned, really qualified, but they might feel reluctant to step forward to earn endorsement. And then there's folks on the other end of the spectrum who just heard about infant mental health and kind of became on fire about it and want to hurry up and get endorsed and get those letters behind their name. And those are the folks that we sometimes have to remind that it's a journey and not a race in terms of really building their competency over time. So I just wanted to give a couple quick details about this Alliance for the Advancement of Infant Mental Health that we keep referring to. As Ashley pointed out on the slide, it includes a total of 24 state infant mental health associations, well, one of those being Western Australia, so not technically a state. And they're all now shareholders in this corporation that was officially born a week ago today. So the Oregon Infant Mental Health Association is now a shareholder in the Alliance and will have like a stock certificate and everything. But along with in terms of like the collective work that we do together and ensuring quality and reciprocity and supporting one another in terms of research and training and building capacity, the Alliance is also hoping to take on some of those bigger projects, as Ashley said. When Michigan first created this system, no one there ever dreamt that it would ever go anywhere beyond Michigan. But as more and more states showed interest and more states grew, our office didn't grow. We had the same number of people offering the support to, increasing number of associations. And so it became apparent to the Michigan Board of Directors, the Miami Board of Directors, that we needed to really form two organizations. So now the Michigan Association for Infant Mental Health remains as a statewide membership organization. It looks a lot like your association. And the Alliance is taking on the training and technical assistance, the quality assurance piece, supporting all the other places where they're implementing endorsement. Along with that, in terms of expanding what we're able to do, I think I sort of alluded to, at the moment, there's only the infant mental health endorsement, but we are developing early childhood mental health endorsement standards for those folks who work with infant mental health informed principles in mind, but work with 3 through 5-year-olds. Also, a big project that is really in part thanks to Christy Cox and the Ford Family Foundation and the Oregon Infant Mental Health Association is that we're beginning to translate all the endorsement materials into Spanish. So that will be, yes, a big, huge win. Yeah. There's also, as Ashley mentioned, the desire to always build capacity in terms of reflective supervision. So the My Aim and the Alliance are co-sponsoring the very first annual Reflective Supervision Summer Symposium this August in Ann Arbor, and folks from all of the Alliance member states will be coming to be a part of that two and a half day event, training event. There's also an annual retreat every year where leaders from each of the Alliance member states gather together. We're going to be gathering in Scottsdale this year to, again, sort of talk about our shared vision and also share resources with one another about how do you implement this successfully, how do you help this break down the silos and help systems work together toward a common goal, how do we build capacity in terms of competency-based training. So that will occur in October. And then the other pieces that are coming along with the Alliance that had previously belonged to My Aim and are because of their national and international spheres, they're going to come with the Alliance. And that's the Infant Mental Health Journal. I don't know if any of you subscribe, but it's a fantastic journal. It's becoming better, I think, all the time. And I mentioned there's going to be an issue dedicated to reflective supervision and consultation. And the other thing that's coming with us is the evaluation of infant mental health home visiting. You know, how I said earlier, gosh, doesn't everybody have this? Michigan's the only place that has this and has it so widespread. And it's been supported and protected for 38 years, but there's not been a randomized control trial of it, and so it's not yet considered an evidence-based intervention. And so there's evaluation happening right now of that model, and the hopes that then other states who wish to expand their spectrum of services that are available to families, those who have promotion and great prevention services, but their only option for referring a higher need family is to refer the mom for outpatient services somewhere, that those states could then say, oh, this is an evidence-based model that we could implement in our state so that we really have a fuller spectrum of services available for all the families who need those services. So stay tuned. We'll be talking more about all of those things as they come. But mostly I wanted to welcome you all to sort of like the Alliance family. We were talking at our table earlier today about the isolation, I think, that a lot of infant and family practitioners, certainly a lot of our infants and families experience, whether they're the isolation of being in a rural environment without transportation, without access to services, or even some of the families in metropolitan Detroit area. We have so many families who've come to this country from other places and feel very, very isolated. And I think that sense of isolation can sometimes affect the practitioners then who serve them, particularly those who are doing it in a home visiting setting, that they might be going from family to family all day long without connecting with another peer. And sometimes I feel like it can feel that way to people in their state too. You all are believers in the power of infant mental health and that everybody needs to be infant mental health informed. But you all go to places and you sit at tables where there aren't other people who believe the same things that you believe. And sometimes it can feel a little, you can sometimes feel a little isolated if you're the only one at the table who's like, but what about the baby? But what about the baby? So hopefully it will feel like as you join the Alliance, you've joined this larger family of people who are all sort of fighting that same fight in their own places and their own regions. So we welcome you, and we're so glad that you've joined, and we're all in this together now. So thank you. So I wanted to see if there were any questions that people had. We've been talking for a long time, it feels like, and talked about a lot of things. Yeah.
How is the Michigan infant mental health home visiting model paid for?
She asked, how is the Michigan Infant Mental Health Home Visiting model paid for? It's all funded by Medicaid. Yeah, I know. We were talking earlier today about champions, and I mentioned this woman, Betty Tableman, who was the one who kind of said, we need this everywhere, and it has to be for all of the babies in Michigan. This woman has retired from state government. She's 93 years old, but she sits on our board, and she still has a lot of influence. It's in part due to her. She's still a champion, and she's been a voice that's helped protected that. But as things change in the world, it's not an evidence-based practice, and so even that Medicaid funding is now threatened until we have some really solid data. Other questions?
Are there other states doing the same thing?
The infant mental health home visiting. There are folks in Washington State who have a very similar approach. There's in Connecticut and some other places, there's a program called Child First that is a very similar to infant mental health home visiting model. In New Mexico, they have an infant mental health home visiting model that's provided through their behavioral health system, public behavioral health system. Folks who do Minding the Baby, the Arietta Slade model of intervention, do something that looks very much like what we've been describing. And as Ashley mentioned, the Circle of Security, that's not a home visiting model, but the longer 20 plus weeks where they do video feedback with the families, in addition to sort of the usual parent education, parent support piece, is another model that folks are using. Yeah.
When you say it's paid for by Medicaid, is it a fee-for-service kind of, you do 8 visits to get paid for 8 visits, or is it more of a base rate or global budget?
I don't know if I know the exact answer to your question. I will say that it's not a fee for service, that I know. It is a bundled service in that in addition to the infant parent psychotherapy, that's what makes the infant mental health home visiting model unique. So all the practitioners are expected to provide that to families, but they also are expected to be doing the advocacy, the developmental guidance, the case management. They're all things to that particular family. And so that's part of how the fee structure is built. But I'm afraid I don't. I have somewhere I could show you. I have the Medicaid regulations in a giant document on my computer. We can look it up and see if that makes sense.
Maybe we'll trade cards.
Yeah, that sounds like a good idea. Yeah, back here.
How big are the caseloads?
Ashley, do you want to answer? The size of the caseloads for the infant mental health home visiting model vary from program to program, but
It is written into the Medicaid guidelines, however, that it should be 10 to 12 because you are providing all of these services. So on average, you spend 2 hours a week with each family. So,
yeah.
but like Nicole said, not everyone follows that guideline. There are some programs who expect their practitioners to have 14 or 15, and there's others who stay very true to 10 to 12.
Part of what the Alliance has done is built a program certification manual so that once infant mental health home visiting does become an evidence-based practice, there'd be a way for someone to become certified as what we're calling early attachments. And so those program standards also lay out what's the ideal caseload for a therapist who's working in this particular way with this particular model. And it is in that 10 to 12 range, again, because a lot of families are getting more than one home visit a week from their practitioner. Yeah.
I was wondering if you could speak to, like, in the Alliance states, how many folks are already endorsed or in the process?
There are currently over 1,600 people who've earned endorsement across the 23 states plus Australia, and there are currently 800 in the process of applying for endorsement. That was at the end of 2015. Those were our numbers, so we gather them once a year. So I'm sure those numbers are going up as we speak. Yeah. Well, we're going to be around today and tomorrow, so if other questions occur to you, please seek us out. We'd be happy to answer them. We want to do everything we can to support this being really successful here in Oregon. So thank you for having us.